Everyone. Welcome to our CAMS and Lantern program. My name is Jamie Love. I'm the administrator for the Chinese American Medical Society. Just want to say thank you to our friends at Lantern, Eliza, for doing this program with us again this year. I think this is our fourth or fifth program together.
I lost track.
So did I. We're very happy to have you continue this program with us. So without further ado, I'm gonna turn it over to Liza.
Thank you, Jamie. First of all, I'm gonna share screen. So, yes, good evening. My name is Eliza Ngan Ditkin. I'm the program supervisor of Lantern Lupus Asian Network, which Dr. Philip Kahn is a respected community advisory board member. We are delighted to be here this evening. Very much appreciated this collaboration opportunity. I'd like to share a little information about our program. Lantern Lupus Asian Network is the only national hospital-based bilingual support and education program for Asian lupus patients and their family. As you see from the slide, the services that we provide are designed to help our members to learn and cope with the conditions so that the quality of life can be improved. These programs are culturally tailored to the needs. Furthermore, we do count on our community partners such as camps to help increase lupus awareness in the community. Lupus is still little known and misunderstood among Asians. We learned that patients don't talk about this disease very often, mainly because of the associated stigma in society. Asian culture may also impact how people manage their health. As you know, Asians are generally shy and tend to conceal their feelings, and oppressing emotions may impact health, particularly mental health. This is especially apparent for people living with a chronic illness like lupus. We aim to close the gaps and make sure patients get the treatment and support that they need in a timely manner. We value our partnership with you and would appreciate it if you let those who may benefit from our resources and services know about Lantern. If you have any questions, feel free to reach out to me on the phone number on the screen. Thank you. I'm turning it back to Jamie. Thank you.
Okay, so I'm going to turn it over to Dr. Victor Chang. Dr. Victor Chang is our current president of CAMS.
So I'd like to thank you all for coming, and it's my pleasure to introduce tonight's speaker, Dr. Philip Kahn, who is Associate Professor, Department of Pediatrics, and Director of the Division of Rheumatology at the NYU Langone Medical Center. Recently, Dr. Kahn has established a new multidisciplinary clinic focused on children with complex autoinflammatory diseases and rare diseases where genetics may be an important part of the diagnosis. So please join me in welcoming Dr. Kahn, and we look forward to hearing his comments for tonight's lecture.
Hi, thank you so much, Dr. Chang, and for staying so late. That's a very, very large sharps container behind you, so be careful. Can everybody see my screen?
Yes.
Okay, good. So we're going to go over, the topic tonight is going to be autoinflammatory syndromes. I titled it From Super Rare to Relatively Common. I have, let me see, does this advance? That's a good question. Oh, there we go. No disclosures. These are some suggested references. Initially, we're going to go over a background of autoinflammatory disease, starting, of course, with definitions. As a part of this, although there's genetics also involved, we're going to emphasize the importance of clinical history and exam, as well as the clinician, especially the general, as having a high clinical suspicion for autoinflammatory disease. I'm going to briefly review some background on pathogenic mechanisms which mediate the biology, and I'm going to briefly talk about the inflammasome. And we're going to review a couple of inflammatory syndromes. And in the end, I'm going to make some final remarks and pose some clinical challenges. So in terms of definitions, this is always a little bit of a challenge. In terms of what autoimmune disease is, it's thought to be a syndrome in which there's an issue between self versus non-self in terms of developing a tolerance to yourself versus non-self, recognizing something as foreign. In autoimmune disease, typically it's more involved the adaptive immune system with T's and B cells, as well as the presence of characteristic autoantibodies, such as in lupus. But in autoinflammatory disease, this is not, for sure, not characterized by the presence of autoantibodies. The inflammasome plays a role, and rather than the adaptive immune system, it's the innate immune system which seems to be play more of a significant role. Many patients ultimately diagnosed with autoinflammatory disease often present with recurrent fever. And I think I'll try to recurrently emphasize the pattern recognition is critical in terms of that the duration of fever may be hours in patients with familial Mediterranean fever, weeks in another syndrome, and constant in a patient with the syndrome called NOMID. There's some general themes to this, and one general themes is the concept of balance, and as well as the overlapping syndromes of diseases pertaining to autoinflammation, in which you have an increased and elevated, a heightened immune response, especially pertaining to the innate immune system, as well as the adaptive immune system at times. And this is a relative balance in terms of factors involving immunodeficiency. But we'll see that there are being overlapping Venn diagrams of both autoimmunity, about autoinflammation, about immunodeficiency, and even malignancy. A lot of these circles overlap. Autoinflammatory syndromes are a group of relatively uncommon diseases, typically with onset within the first 2 decades of life. Typically, they're often characterized by seemingly unprovoked recurrent episodes of inflammation. Very rarely you'll see patients that have chronic inflammation. Many of these are now identified as monogenic diseases with multiple mutations. And what we see is that there's a genetic defect of proteins which are involved in the regulation of these innate immune pathways. The inflammasome will go over as an important construct. And patients, many of these patients with these syndromes that have recurrent episodes of unwellness are actually relatively well between the episodes with normal growth. As opposed to many other diseases, family history is often important in making this diagnosis, with ethnicity being very important, as for example, in patients with familial Mediterranean fever. In many of these syndromes, one of the reasons we're extra concerned is not only because the patient's unwell and having recurrent episodes of unwellness, but they may carry a risk of amyloidosis. In general, as many of these patients present with recurrent fever, when we think of recurrent fever, especially as I'm a pediatric rheumatologist, we first and foremost always think of infection, of course, typically with viral, occasionally bacterial, and then we get to fungal, parasitic, and atypical infections, and especially with our patients with unusual exposures or travel history. And with infection, we always have to worry. It's easier when it's an overt infection, but it's more tricky when it's an occult infection. In terms of patients that have recurrent fever, especially chronic fever, that we always think of malignancy, of course, depending on where you practice, primary immunodeficiency, and that the fever is a manifestation typically of an infection. Rheumatic disease typically may manifest commonly as fever of unknown origin, including lupus, as well as vasculitis, Behçet's, and other syndromes. And then there are these autoinflammatory syndromes, which we're going to discuss this evening. And lastly, and rarely, occasionally we'll have patients that have fever secondary to drugs, a central fever, which is extremely difficult to diagnose, dysautonomia, and even Munchausen syndrome in pediatrics. But how do you know if a patient has an autoinflammatory disease? I know that this is a very broad audience with people from many different backgrounds. So these patients may manifest with various clinical manifestations, which we'll go over. And in terms of who may see these clinical manifestations, whether it's a head disease, eye disease, swollen lymph nodes, skin disease, musculoskeletal disease, gastrointestinal disease, or geneticists for dysmorphic features, they may be seen by all of these specialists and more to the right. But in terms of breaking down clinically, because I am a clinician, I think of approach this way from sort of head to toe, as these patients may present with meningitis, they may present with developmental delay or intellectual disability, they may present with seizures and various dysmorphic features, such as the patient above here that you can see with these characteristic facial features. These patients may have hydrocephalus, Some of these patients may have these idiopathic intracranial calcifications or various different craniofacial abnormalities, such as the frontal bossing seen in this young boy. Another aspect related to the head and the brain is, I missed a slide over here, is hearing loss. They may also manifest with various skin disease. I'm sorry if you're eating dinner, but on the patient up here, you see a patient with lipodystrophy. This is a patient with these sort of annular lesions, these annular erythematous papules that you see in Still's disease. A patient with psoriasis. This is Raynaud's phenomenon. These are oral ulcers. This is a vasculitic rash here. This is erythema nodosum. This is, and we're going to go over this appropriately with each of the patients that we'll be describing tonight with these clinical vignettes. This is pyoderma gangrenosum. This is erysipelas rash. This is a rash of a genetic form of sarcoidosis called Blau's. And this is a baby that I took care of with a rare syndrome called NOMID. And this is another syndrome we'll talk to you about this patient lastly. Patients who are ultimately diagnosed with autoinflammatory disease may actually present with musculoskeletal disease. They may have arthritis with joint swelling, as you can see this patient with a swollen left knee. This is a patient with an extraordinarily unusual bony overgrowth that has NOMID, another rare autoinflammatory disease. This is a patient with subtle, maybe not that subtle clubbing. And lastly is the patient that may present with bone inflammation or a non-infectious osteomyelitis, as you can see in this patient with a swollen clavicle. In this approach to autoinflammatory syndromes, as well as autoimmune disease, and in the field of rheumatology, often these patients are quite mysterious. And I always bring up this concept of the blind monks and the elephant. And each blind monk feels a part of the elephant and thinks that they understand the elephant. This is, I know that we know this, but the elephant that feels the monk that feels the tail of the elephant thinks that they're feeling a snake. The blind monk that feels the ear of the elephant feels that they're feeling that the elephant is a fan. And the one that holds the tusk of the elephant thinks that the elephant is a spear. And it's only when we step back and we try to put all these little pieces together that we can really truly appreciate the elephant that is the patient that has autoinflammatory syndrome that has all of these variable clinical manifestations. So we always want to look for the elephant. This is an overview of some of the fever syndromes. These also used to be called hereditary fever syndromes and periodic fever syndromes. And although these may present in childhood or underneath the age of 20, many of these are still, especially with better treatments, continuing to adulthood, and we'll go over some of these syndromes. Fortunately, there is a genetic testing that is now really, really unbelievably widely available now, including 156 genes. You don't need to be a rheumatologist to order this, although I would caution you in ordering this extensive panel, which can be costly. But we're going to start talking about some patients. And the first patient I wanted to talk to you about today is the most common patient that I see. This is a 2-year-old who's seen in the emergency room with sore throat and fever for 2 years, 2 days. That's pretty benign. But this is the 4th visit for this 2-year-old in the past 6 months, previously diagnosed with viral pharyngitis because the strep test is negative. There is a complete recovery between these episodes, but you discover if you look at their gums, you see these canker sores, these aphthous ulcerations present. You see these big, beefy, red, swollen tonsils. And when you palpate the neck, you see very prominent cervical lymphadenopathy. If you do lab testing, you'll see a mild elevation in white cells, a mild elevation in CRP, and the throat culture is typically negative and should be negative for strep, although this may look like strep. But this is, in fact, a patient who has the most common autoinflammatory syndrome called PFAPA or PFAPA, which stands for periodic fever, aphthous ulcer, pharyngitis, and adenitis syndrome. It is far and away the most common autoinflammatory syndrome. We don't know what causes it, but it's a childhood onset, more common in males, and it typically resolves by the age 12. But this syndrome can continue in adulthood. And in Israel, where there are people that follow autoinflammatory syndromes, they actually have a cohort of adult onset PFAPA. So you can still see this in adulthood, though it typically burns out, and it's characterized by identical recurrent episodes of fever with tonsillitis and swollen glands. There are ill-defined diagnostic criteria with a lack of consensus, but there are no specific confirmatory tests nor is there any gene that's associated with this syndrome, although it is included under autoinflammatory syndromes and is far and away the most common. Fortunately, these kids have normal growth, and the treatment, in terms of the acute treatment, is with prednisone. Prednisone is a moderate dose of prednisone between 1 to 2 milligrams per kilogram. And within one dose, within hours, it is like magic. These kids have a total resolution of their fever that may last for 5 days and instead lasts for hours with the use of prednisone and does not come back, although the interval between the fevers may shorten, meaning that the fever will come back, but the fever for that acute flare will not come back once you give prednisone. And tonsillectomy, for reasons that are unclear, is curative in over 95% of these patients. And these kids, the way that the diagnosis is made is that the parent makes this diagnosis, because they even label the fever with the child's name, like Billy's fever. The fever is identical. It's every 4 to 6 weeks, like clockwork. The parent knows when it's going to come. It lasts for 4 to 7 days. And this is a patient, although we know that children commonly have viral URIs, this patient should have nothing to suggest that they have an upper respiratory tract infection with these flares. There are non-specific labs that we might see, but they're totally non-specific, like leukocytosis with a left shift and mild elevation of inflammatory markers. But these labs also normalize when the child is no longer febrile. Typically, imaging testing is unhelpful. And there are some patients, not patients, but maybe patients and parents, but there's some physicians that rather than treat the acute episodes with steroids or try to cure the episodes with tonsillectomy, some parents and some doctors may use cimetidine, an H2 blocker, or colchicine, although it's typically less responsive. These children do great long-term outcome, normal growth, and there is no risk of secondary amyloidosis. But here's another slight variation. This is a patient also with recurrent ulcers. This is an older patient. This is a 32-year-old Turkish woman who's had long-standing recurrent aphthous ulcers for years. Thought to be idiopathic, maybe related to diet or stress, and more recently, she's treated for presumptive herpes because she's also recently started to develop recurrent genital ulcers. She's developed arthralgia with fatigue, anorexia. She has now developed chronic diarrhea and has a 10-pound weight loss. Recently, when you examine her, you note these pink, tender nodules over her shin. And although you definitely suspect that she could have Crohn's disease, another potential consideration in this patient with both oral and aphthous ulceration should be Behçet syndrome, which is still a clinical diagnosis. What makes your heightened diagnosis is the ancestry of the patient, the origin, the ethnicity of the patient, and the fact that she comes from Turkey, as it's more commonly seen in countries that are along the spice route in the Middle East and Asia. And there is a greater prevalence of HLA-B51, which physicians may check periodically, although I don't find it particularly helpful. It's just a curiosity. The age of onset is typically in the 30s to 50s, but it may be seen in childhood. In terms of what we see clinically, we already talked about the recurrent aphthous ulcers, luckily that they do not scar in the mouth, but the patient may have various genital ulcers of the scrotum or the shaft of the penis or vulva in women, and that may unfortunately scar. And they can also have pathergy or a reaction when they put a needle into the skin that you develop a pustule, as well as separately you can have a neutrophilic dermatitis over the elbows. As I showed you in the previous slide, the patient may have erythema nodosum, acneiform lesions, and pseudofolliculitis. What's very challenging with these patients is they can have very, very severe inflammatory eye disease, such as uveitis and retinitis, which can be very difficult to treat. They can have CNS vasculitis, meningitis, headache, and ataxia. They can have both arthralgia with joint pain, as well as arthritis with frank joint swelling. And they may, as in this patient, have various GI manifestations. And some say that even the biopsy, if you do endoscopy, is very similar to Crohn's sometimes. In terms of vascular manifestations, they may have vasculitis. Separately, they may have aneurysm and even clot. These patients are treated based on symptoms, including NSAIDs and colchicine, but various immunomodulatory medications, such as anti-TNF medication, such as Humira, is used for more severe manifestation, such as uveitis or CNS involvement. This is another similar patient who is also presenting and is also from Turkey. This is a 10-year-old with recurrent bouts of fever in the past year. Most of these episodes are accompanied by severe abdominal pain. This kid is bent in half and howling with severe belly pain. You can't touch his abdomen. And occasionally there's right-sided pleuritic chest pain with inspiration. During one episode, he actually had such severe belly pain, he underwent appendectomy, as when the ER doctors sent lab testing, there was also leukocytosis and elevated acute phase reactants, although ultimately the appendix was sterile. He's been treated with antibiotics on several occasions, including one time when he was noted to have a right-sided pleural effusion. Some fever episodes are extremely brief, resolving in hours. There is complete resolution of symptoms in between flares of disease, and interestingly, there are several family members with identical symptoms. And the most likely diagnosis for this patient is familial Mediterranean fever, which is the most prevalent monogenic autoinflammatory syndrome. It's been characterized in the late and early 90s by a mutation in MEF, Mediterranean fever gene, which codes for the protein pyrite, which regulates IL-1 beta, which is a significant player. It's an autosomal recessive disease with over 80 mutations. And the gene may actually be present in healthy people who don't, in fact, have familial Mediterranean fever. The diagnosis and when to suspect it should be in patients who have an ancestry or family history where there's a higher prevalence of this syndrome. The age of onset is typically less than 20 years of age. I've seen kids less than 2 that present with it. And it's characterized by these recurrent episodes of belly pain, chest pain, arthritis, fever, and here we see an erysipelas-like rash. But often, as with most things in medicine, it's an incomplete clinical picture. In terms of treatment, lifelong colchicine is still required. It's extremely effective in both reducing the frequency as well as the severity of the flares of FMF, as well as reducing the risk of secondary amyloidosis, which is still seen in up to 60% of untreated patients and may result in renal failure. In terms of what is the big player, the inflammasome is really the big player in these syndromes. And this is a complex cytosolic structure involving caspases and sensor proteins and nod-like receptor families, which ultimately activate caspases and ultimately mediates the maturation and activation of pro-IL-1 beta, which becomes IL-1 beta. And this is really, we know of IL-1 as the sort of fever, right? The fever cytokine, as well as other effects that are mediated by IL-1 beta. But fortunately, IL-1 beta is naturally inhibited by its natural antagonist, which all of us produce in response to elevated IL-1 beta, which is IL-1 receptor antagonist, which is secreted in response to inflammatory stimuli. There's a group of inflammasomes called related to NLRP, which recognize, and for reasons that are unclear, typically and historically, these are involved in recognizing danger or damage with PAMPs and DAMPs, as well as bacterial products, which were common to know, such as the classic, the ones with polysaccharide with LPS, as well as other damage syndromes. And the inflammasomes, the more that when these came out, then they seem to play a significant role in both gout, pseudogout, type 2 diabetes, and even atherosclerosis. But in autoinflammatory disease, there may be a mutation pertaining to the loss of a regulatory step in the formation of this structure, in this complex, and therefore spontaneous assembly with inappropriate production of IL-1 beta may result in disease, meaning that we like the inflammasome when it's supposed to act appropriately. When the body is seeing damage and you're developing and it gets everything into play, but there's something off with these autoinflammatory syndromes where it's not behaving appropriately. We're going to go over these various cascades here, and we're going to touch on some of these syndromes here. And here in the red, you can see we're talking about pyrene and familial Mediterranean fever. And this is just a visual of this inflammasome structure, which is not just it's a very complex structure, which is cytosolic. In terms of back to the clinical and familial Mediterranean fever, these patients suffer. They have really impressive flares of serositis, and if you look at the tissue, there's lots of neutrophils in the tissue. And neutrophils appear to play a significant role in terms of the biology of this disease. It's really like a recurrent episodes of serositis, so cirrhosis of the lung with pleuritis, pericarditis, arthritis, and even peritonitis, which is why they have such severe pain. The frequency of the attacks can last weekly, to several times a year. And again, this is a very unusual syndrome because the duration of the attack may last 4 hours. Colchicine has still been used since the 70s to both control and prevent the attacks as well as prevent amyloidosis. And I have a picture here because colchicine is one of my favorite medicines because it completely comes from the flower of the autumn crocus, the Colchicum crocus that comes up in the fall. It's been used for over 2,000 years. It's still relatively inexpensive, and it's safe, lifelong. There's no other medicine that's as safe, lifelong, but it has a relatively narrow therapeutic window, meaning there are kids that are adults that still purposely overdose on colchicine because they're trying to take their own life. But if you're using it at the appropriate dose, there's a discussion whether or not you even need to do any drug monitoring for this. In terms of adverse effects of the colchicine, you can have some diarrhea, belly pain, nausea, and transaminitis, which can be challenging because you're using colchicine to treat a disease that's characterized by flares of abdominal discomfort, yet the drug can also cause abdominal discomfort as well. This is another, since it's like, oh, I think FMF only occurs in the Middle Eastern. This is a boy that I saw just on Friday, a 12-year-old Chinese-American boy born in the US who is otherwise well with 2 prolonged bouts of recurrent fever, weekly for 1 month and then monthly lasting for several hours, up to 3 days, high fever, headache, dizziness, tiredness. At age 6, this occurred over a 10-month period, and now at age 11, it occurred over an 8-month period. The status post extensive evaluation by infectious diseases and even oncology, and incidentally, the oncologist ordered this panel not even knowing exactly why, and he was discovered to be homozygous positive for familial Mediterranean fever, sort of surprisingly to the oncologist because he wasn't suspecting it. There's no family history, and now this child has been healthy for the past 4 months. One question is, well, since he's been healthy for 4 months, do we necessarily need to start colchicine today and for the rest of his life? Question mark. This is another boy another classic patient that might be seen. This is a 5-year-old with fever and rash. This patient's been having daily fever for 3 weeks, a classic pink rash that comes and goes over his arms, legs, and trunk. He is sick appearing. He's got a swollen liver on exam. He's got a swollen spleen. You can even see the lymphadenopathy. And when you examine him, he's got arthritis of his neck, his elbows, his wrists, and he's got pericarditis on clinical history and exam. And the most likely diagnosis for this boy with 3 weeks of daily fever is systemic JIA or Still's disease. The infamous Still's disease comprises, fortunately, only 10% of juvenile arthritis, though a significant amount of its morbidity and mortality. It does not discriminate based on gender, any age, and of course, we know about adult onset Still's disease, which is probably more relevant for many in this audience, in which the patient is presenting with recurrent quotidian fevers for at least 2 weeks and the classic textbook salmon-colored rash that is evanescent. By evanescent, it means that when this patient has a spike, they spike at 8 in the morning, 8 in the morning, 8 in the morning, or 8 a.m., 8 p.m., 8 a.m., 8 p.m., at least for several days in a row. It's very bizarre. That's the quotidian fever. And when this child or patient is with fever, that is when the rash comes on. That's why they call it an evanescent rash. Typically, although it's not as common in pediatrics, although kids have more sore throats, adults with Still's disease frequently report sore throat. It's always a diagnosis of exclusion, and rarely you have any rheumatoid factor or ANA. And what challenges this diagnosis is the arthritis may not be present at diagnosis, and uveitis is rare as well. There's a rare risk for amyloidosis. We really don't see that as much anymore. And fortunately, we have better treatments. Historically, these patients only were treated with prolonged courses, sometimes years of systemic high-dose steroids, as well as other immunosuppressants like cyclosporin, cyclophosphamide, and even thalidomide. And initially, when anti-TNF therapies came around in the early 2000s, they didn't seem to work, especially etanercept. But then, IL-1 beta seemed to be a significant pathogenic factor in terms of mediating this disease. And unfortunately, IL-1 receptor antagonist called anakinra is therefore used to treat this syndrome. It's in fact recommended now as the initial steroid-sparing agent for patients with Still's disease. And some patients are in fact treated with minimal to no steroid when they use anakinra at diagnosis, although the anakinra does not seem to be as effective in patients that have arthritis. In terms of other anti-IL-1 medications that are used, they include rilonacept and canakinumab, as well as the infamous tocilizumab or TOSI that has now gotten significant fame in the COVID days. So you've admitted your suspected patient with Still's disease. You're called by the resident who states he doesn't look good. He is now somnolent with mucosal bleeding, although the resident is reassured that it's probably not inflammatory since his SED rate that was 120 has suddenly dropped to normal. And your immediate concern is macrophage activation syndrome. This is a stolen slide of a patient bone marrow slide with a macrophage that has blood cell components within the macrophage. And this syndrome is a secondary or a reactive hemophagocytic lymphohistiocytosis, also known as MAS. It has imperfect clinical criteria, but we see this this syndrome, this sort of complication in patients with Still's disease, as well as Kawasaki's, a pediatric vasculitis, and lupus. And most recently, we've been seeing this syndrome in patients with cytokine storm of COVID, especially pediatric patients. This is a potentially life-threatening cytokine storm that involves pancytopenia, hepatitis, which may progress to coagulopathy and bleeding, as well as neurological dysfunction, including coma, with a mortality of up to 20%. Approximately 10% of patients with Still's may develop this, and the pathogenesis is thought to be related to the fact that the NK cells and the CD8 cells have impaired cytotoxicity, and there are issues with how these cells can degranulate their toxic cells, their granules. There may be issues with perforin and endothelial cell activation as well. What is characteristic for this syndrome in terms of laboratory testing and when you suspect it is they have a profound elevation in ferritin. I don't know if you know normal values, it's supposed to be less than 200, and these patients may have ferritins of greater than 10,000, as well as elevated soluble IL-2 receptor. Although you often or should or often request bone marrow biopsy, you may not in fact see hemophagocytosis in bone marrow, and sometimes you may see it in the liver as well, but you may not find it. But again, it can still be that the patient has this syndrome. In terms of how you manage these patients, it's always suspected. With most of these patients, you always have to have a heightened level of suspicion in the patient that has an underlying disease and they're acutely worsening. Prompt recognition and action is critical. Patients may present in a very dramatic fashion. Like in this patient, they have a precipitous fall in their SED rate because you need your SED rate, fibrinogen, to make a SED rate. And these patients are becoming coagulopathic. They're either losing their fibrinogen, it's being consumed, or it's not functioning appropriate. So they can't make a SED rate, but these patients are still febrile, they're still pancytopenic, they still got a sky-high CRP and a ferritin, and they're sick. Symptomatic management, ICU management, of course, fluids, metabolic derangement has to be corrected, and you manage the seizure and a coagulopathy, but empiric high dose, what we call pulse dose steroids up to 1 gram daily for 3 days is required, and newer biologics that we talked about targeting IL-1 and IL-6 are helpful. And still, they're from older, depending if a hematologist sees this patient, in terms of what is used for HLH, the hematologist may recommend cyclosporin A, as well as etoposide or ATG, which is still used. I wanted to change gears and talk about a totally separate group of patients. These are 3 separate patients that have the same diagnosis. This is a 10-year-old girl with recurrent jaw pain. She's seen multiple dentists, oral surgeons, a chiropractor, and there is a consideration that she will require significant jaw reconstruction and remove her mandible and replace it with a piece of steel. There's a 15-year-old girl that has multiple bone biopsies for recurrent leg pain, status post multiple courses of IV antibiotics for recurrent acute osteomyelitis without any culture positivity. And there's a 12-year-old boy with recurrent episodes of clavicle pain. On physical examination, you see this bony prominence, some mild tenderness, but because of the recurrent episodes of clavicle pain, and there happens to be episodic fever and elevated inflammatory markers, there's a concern for possible underlying malignancy. But what in fact these patients have is inflammatory bone disease. Inflammatory bone disease are osteomyelitis or osteitis can be seen in patients with autoinflammatory syndrome. These are the various names. We're only going to go over the first one, which is chronic recurrent multifocal osteomyelitis. So initially, these patients were described as a non-bacterial osteomyelitis, and really then changed into chronic recurrent multifocal osteomyelitis. But what these patients have is recurrent episodes and sometimes chronic episodes of sterile bone inflammation. This is the most common autoinflammatory bone disease. The disease onset is typically prior to age 21. Fevers, although they may be seen, are typically not very, very prominent. And inflammatory markers, although they may be elevated, may be in fact normal. In terms of where they have inflammation, it can be almost anywhere in the body. It may affect long bones, but when it affects long bones, especially if it's a pediatric patient, it's near the metaphysis of the long bones of like the femur or the tibia. It can be seen in the pelvis, like around the ankle, and in this patient, the clavicle and the vertebra. And you can even have it on flat bones like the scapula, and you can even have it in the skull bones. In terms of what you look for, you can look for psoriasis. Often there's a family history of psoriasis as well. There may be arthralgia, arthritis, and there may even be Crohn's disease, in which you ultimately diagnose this patient. Again, back to seeing the elephant, they present with non-infectious osteomyelitis, but the elephant may in fact be Crohn's disease. There is no gene that's been associated with chronic osteomyelitis. There's a worldwide distribution, and how you treat these patients is extraordinarily variable. You could treat with NSAIDs, methotrexate, interferon alpha and gamma, anti-interferon, anti-IL-1 therapy, and even pamidronate can be used in patients. Of course, this is tricky. Everybody wants to talk about evidence-based medicine, but there are developed consensus treatment protocols in terms of how to treat this non-infectious osteomyelitis. In terms of other syndromes we might see, you can see hyper-IgD syndrome, previously known as mevalonate kinase deficiency. This is an autosomal recessive mutation of mevalonate kinase genes that encodes for mevalonate kinase. Two-thirds of these patients may present in infancy. They have these attacks in which they have various symptomatology, including fever, lymphadenopathy, belly pain, vomiting. They can have severe vomiting pain, diarrhea, headaches, arthritis. The attacks may be precipitated by viral infections and even vaccinations and trauma. Most of these patients, which is why we call it was called hyper-IgD syndrome, is because IgD, like David, can be elevated, but you may have other elevated gamma globulin, including IgA, as well as elevated inflammatory markers. We don't check I've never been able to check for urinary mevalonic acid. We can check for this mutation. And secondary amyloidosis, which again can be seen in many of these syndromes, is uncommon. In terms of how you treat these patients, they're typically treated, if it's mild, with NSAIDs and steroids, although etanercept, which targets TNF alpha, as well as anakinra, which targets IL-1 beta, have also been used. Another unusual syndrome is TRAPS, which is also previously called Hibernian fever, which is an autodominant syndrome with incomplete penetrance, which results in a genetic defect in the gene encoding this 55 kilodalton TNF receptor, which is misfolded and unable to get to the surface to interact with TNF, resulting in inappropriate inflammation. These patients may have disease onset in infancy or even later in adult years. And what is typically characteristic of this fever syndrome is they have long episodes of fever. So most of the other fevers that I've talked about are relatively short, but this patient may have long episodes lasting for weeks. And one characteristic feature is this rash that they have is a tender and migratory rash. We typically don't see patients that have migratory rashes. Although colchicine is used for various autoinflammatory syndromes, it doesn't respond. This syndrome doesn't respond. And so patients are typically treated and have a very good response with etanercept, but still use glucocorticoid steroids for flares of disease. And this is a patient that carries the risk of amyloidosis, which is why it's important to treat them. Also, they're unhappy. I wanted to go over here a bunch of these more rare syndromes involving cryopyrinopathies. So again, cryopyrinopathies are back to some dysfunction. They're a group that are related to a mutation of a single gene called NLRP3 at chromosome 1, which encodes for, rather than pyrin of FMF, this is cryopyrin with autosomal dominant inheritance and variable penetrance. The syndromes that we'll talk briefly about are the ones above. One is characteristic with many of these patients that they have this urticaria-like rash, but it's typically not itchy, not as itchy as urticaria, and it does not respond to antihistamines. An unusual feature is that it can be elicited by cold exposure. Cryopyrin acts as I don't want to get back on the inflammasome, and anakinra is effective in many of these patients. This is the mildest phenotype. This is what's called familial cold autoinflammatory syndrome. And what is very unusual is that upon cold exposure, this patient develops fever, urticaria, not that itchy again, conjunctivitis and arthralgia. You can see leukocytosis. It may develop in infancy. And the duration is relatively brief, less than a day. And again, although they do have urticaria, it does not respond to antihistamines. These are mainly Europeans that have this, and it's considered the mildest of the cryopyrin-associated disorders. And uncommonly, these patients uncommonly develop secondary amyloidosis. Again, the main treatment is avoidance of cold exposure, which seems to elicit their disease. But if you need to, you can use anakinra targeting IL-1 beta. This is Muckle-Wells, again, mainly European ancestry, that has recurrent episodes every few weeks, again, lasting relatively short for 36 hours, variable age of onset. Some interesting feature with this syndrome is that they can have sensory neural hearing loss that develops in the second or third decade of life. And the interesting thing is, although they develop this hearing loss, they can have partial recovery of their hearing loss with the use of subcutaneous daily injections of anakinra. So this is an inflammatory hearing loss that is responsive to immunomodulatory therapy. Again, some concern for secondary amyloidosis. This is a very, very unusual syndrome called NOMID, which is neonatal onset multi-system inflammatory disorder that was called something previously. Any ethnicity can be affected. It's the most severe associated cryopyrin-associated syndrome. These patients have characteristic faces with frontal bossing characteristic. And one of the things that's unlike the other syndromes we've been talking about is that this is a chronic, constant period of inflammation in which they have fever, they can have chronic meningitis, they can have cerebral atrophy, mental retardation, or intellectual disability is more appropriate, sensory hearing loss. Say again? Oh, sorry. Sensory neural hearing loss, uveitis, lymphadenopathy, and impaired growth. Before we had medications, these patients would die early. One of the most interesting features of this patient is they have this bizarre bony overgrowth of their epiphyses. This is the classic, this is an not obviously, but an untreated patient that has this really, really characteristic, unusual overgrowth at growth plates and epiphyses. And we worry about secondary amyloidosis in this patient. This is the first patient I met. She was at this time, she was about 4 months old, that had daily fever and a very unpleasant looking rash. When she was older, she drew this picture of herself, and she required, this was just when we were starting to use anakinra, and it's a daily injection, which is upsetting, of course, to give a child or anybody a daily shot, but it may treat, prevent, and even improve the inflammation, including their aseptic meningitis, including the papilledema, and including the cochlear inflammation. These patients, prior to treatment with anti-IL-1 therapy, would become deaf. Now, with treatment, the hearing loss can reverse. You sometimes may require high doses. This is a very high dose, but unfortunately, the bone and joint abnormalities are less responsive to anakinra. These are the last few slides I have. This is a patient that I met when she was 4. She came because she had a very, very swollen wrist with really minimal pain, and she could move her wrist relatively well. Several months earlier, she had this fine rash here, and she underwent a skin biopsy of this fine, it's supposed to be papular rash, which demonstrated non-caseating granulomata in her skin. And on exam, although she reported came in reporting one joint, but when you did a full exam, she had over 10 joints that were swollen, boggy, relatively non-tender. And interestingly, her father had been treated by my partner with a presumptive diagnosis of juvenile arthritis. Genetic testing ultimately confirmed the diagnosis in the father and daughter, and 2 years later, she developed chronic and very medically recalcitrant uveitis. And she, in fact, had a diagnosis of Blau syndrome, which is a form of sarcoidosis thought to be labeled by some as juvenile sarcoidosis or pediatric granulomatous arthritis. You can have a clear mutation of NOD2, which can be seen in other syndromes as well. It's autosomal dominant, as in the case of this child. It may present in early childhood. It may also be sporadic or familial. The triad is characteristic and is present in this patient. They have this classic boggy arthritis, which is very strange. It's really this thickened synovium. They can have this fine scaly rash. Non-caseating granulomata may be seen in the skin, but also may be seen in the conjunctiva and even in the synovium if you biopsy them. They may have uveitis that affects the entire eye, which can be very tough to treat. And they can have cranial neuropathy and IBD-like disease, camptodactyly, and other manifestations. In terms of how you treat this patient, in fact, this patient is ultimately on infliximab or Remicade, which targets TNF-alpha as well as CellCept, but other options are NSAIDs, steroids, methotrexate, and anti-IL-1 therapy, which I'm considering for my patient. This is another patient who I've seen, had seen for years. Now she's gone to see the adults, but she's been followed for years since birth, since soon after birth, when she presented with recurrent episodes of fever, colitis, arthritis, Raynaud's phenomenon, cold urticaria, asthma-like lung disease, elevated inflammatory markers requiring chronic steroids for years without any overt response to cyclophosphamide, IVIG, etanercept, infliximab, which targets TNF, adalimumab or Humira, thalidomide, cyclosporin, tocilizumab, and others. Her most troubling manifestation was this very unusual rash with this sort of bruise-like purpuric rash that would then become scaly and then ulcerate and weep and sort of weep and ooze, which ultimately revealed a granulomatous dermatitis. She had some response to injections of anakinra, though she unfortunately developed an intense pathogy, which I'll talk to you on the next slide. And interestingly enough, both she and her father had the exact same disease. And in fact, she showed me her leg, and the dad said, you know what, Dr. Kahn? 2 months ago, I had the exact same rash in the exact same place. And this is a family that has plaid syndrome. I'm just doing it as an autosomal dominant, extremely rare syndrome that has been described. And this is yet evolving syndromes in which, you know, previously when we talk about bench to bedside, this is where you go from the bedside to the bench and then back to the bedside, which is fun. And these people that describe this is out of the NIH, the autoinflammatory syndrome. And this is the newest syndrome. This is our young, wonderful Dr. David Beck at NYU, who discovered this new syndrome. This is one of the newest players on the block, which is apparently reasonably common, although we don't have exact numbers, which is VEX's, which was described in 2020, in which the patients, and I'll go over the clinical manifestations of their autoinflammatory disease, but it's VEX's, which stands with vacuoles, which you see, these big, large vacuoles when you look at their bone marrow cells. E stands for E1 ubiquitin activated enzyme, which encodes UBA1 gene, which is mutated. It's X-linked, and it is somatic mutations that are acquired and not inherited. And these patients may have variable symptoms, including systemic features of fever and fatigue. They, kind of similar to the TRAPS patient, may have painful rash. They have unusual connective tissue manifestations with pain and swelling of the ear and nose. They can have variable lung manifestations with cough or dyspnea, joint pain, joint swelling, vasculitis, and they may have various cytopenias and even thromboembolic phenomenon. In terms of how these patients are treated, it may include steroids, various immunomodulatory therapy, and unfortunately, or fortunately, if it helps them, bone marrow transplant in patients with VEX's who have severe disease. And although we've been talking about fever, and fever pattern may be helpful, most recently they have in 2020 a new syndrome out there called SIRF, which is a syndrome of undifferentiated recurrent fever, which is a heterogeneous group of diseases which is characterized by recurrent fever and systemic inflammation, usually based on laboratory testing, which is self-limited without confirmed molecular diagnoses. These patients do not fulfill criteria for PFAPA, which we had discussed initially with the child with recurrent fever and oral ulcers and pharyngitis, nor do they fulfill criteria for other autoinflammatory syndromes. They may have multi-organ involvement, and many of these patients still respond to colchicine. So last two slides, we learned the classic in school and then realized that most patients we meet in life are variations of the theme. This is a 5-year-old child who presents with recurrent fever, pharyngitis, adenitis, and aphthous ulcers every 4 to 6 weeks for several days. Normal growth, negative family history. This is a classic story for a patient with the most common autoinflammatory syndrome, PFAPA. A colleague sent FMF testing revealing heterozygous mutation, and you're seeing this patient for a second opinion. Does the patient have FMF or do they have PFAPA? What if this same patient is Turkish, where FMF is way more common, with some statistics of having 1 in 100 or 1 in 200, depending on the population? What if there's a strong family history of FMF? What if the same patient, rather than being 5, presents at 35 with the same symptoms? Does this patient require lifelong colchicine for a presumptive diagnosis of familial Mediterranean fever? The main reason I do this job is that I get to see children like this. This little baby, when I met her, was very, very sick. And this is when she was 4 and she's great. She's now moved to a different state, so I'm no longer her doctor. In terms of the key points that about the talk you just heard, I wanted to remind you that we're talking about autoinflammatory syndromes involving dysregulation of the innate immune system more than the adaptive immune system, largely pertaining to the IL-1 related, beta related inflammasome, which appears to be the important regulator of these autoinflammatory syndrome that is dysfunctionally activated. Monogenic mutations result in several autoinflammatory diseases with variable clinical phenotypes, including recurrent episodes of fever with some exceptions. The duration of attacks may help distinguish syndromes. In many of these syndromes, we worry about the variable risk of amyloidosis, which is why we're even more concerned with treating them intensively and appropriately. In these diseases, we consider family history and ethnicity even more strongly as part of our history taking. Again, as a reminder, PFAPA is the most common autoinflammatory syndrome, and familial Mediterranean fever is the most common monogenic autoinflammatory syndrome. Normal growth and development without amyloidosis risk is always seen in PFAPA. And that is all, folks. Thank you very much for your attention.